Hello, good evening, good afternoon, good morning, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David O'Regan. I'm a professor in the Medical Education Research and Development Unit in the Faculty of Medicine at the University of Malaya. I'm joined this evening by my fellow senseis, Chris Cuddy, Prof. Seeley, and Ardesh, who's just passed his third year in the Faculty of Medicine in Malaya. And congratulations to Ardesh. Jolly good work. So this evening, sadly, we got to start off by remembering one of our fellow senseis. Chris Tagara joined us some years ago as a sensei. He was a professor, assistant professor at McMaster University, then went on to be professor of surgery at University of Alberta, and was president of the Canadian Association of General Surgeons. I sent out a letter to the senseis at the beginning of June, and sadly, Peggy, Chris's wife, replied to say that he had died in January. I did not know this. We are grateful to Chris Tagara for his input on the education side of the Black Belt Academy, and he was instrumental in putting together all the descriptions of the common surgical instruments that we are going to test our candidates on going through the Black Belt. We expect you to be able to name the instruments and know a little bit about them. This evening, we don't have a producer, so forgive me as I'm admitting people as we go along. But coming back to Chris Takara, we're extremely grateful to him for producing these very valuable vignettes about the instrument. And I think with the instrument, to appreciate the instrument and the feel, which is what we want you to understand, it is actually a good idea to learn who designed the instrument and why, because there's an ergonomic reason behind it. Chris also joined us for a discussion on morbidity and mortality. And since we work as surgeons in a show-me environment, I think it's very important that as a surgeon that you collect your complications. And when somebody says, how well do you do? You, I believe, are responsible for demonstrating that not only are you safe, but you're effective and offer a good experience. And Chris and I had a wonderful conversation now 2 years ago and a live on Black Belt Academy. But that conversation is there for catch-up. And I'd just like to spend a few moments in silence remembering his generosity, and he was a true alderman. And I met him at ICASET meetings and the Triangle at the College of Surgeons. So join me for a moment, please. Thank you. Thank you very much. So the other news from the Black Belt Academy is that we had a grading session on Saturday, and the grading was significant because, and Ardesh is on the line, we actually asked our green belt sensei to grade the red belts and yellow belts. And we had 2 red belts, 4 red belts, and 8 yellow belts, and 2 green belts grading on Saturday. And if it weren't for the 3 green belts, Ken, Ardesh, and Shavita, the grading would have been chaotic. But instead, it turned into a remarkable learning environment. And Amar, who runs the clinical skills unit, remarked it was one of the most interesting training sessions that he'd ever seen. because there's no ego in the room. And everybody was learning from everybody else. So I'm extremely grateful to our green belts and their insights and their wisdom and learning of teaching has also lending itself to this transformative process that we are looking at in the Black Belt Academy. And it is very interesting and I think very powerful that as we train basic surgical skills, that we encourage the learners to learn how to train as well. I don't believe that standalone trainer-the-training courses are as effective as learning as you develop. The other thing is to teach and to instruct. One has to deconstruct and learn and reflect at the same time. And that deconstruction and reflection, I think, are important elements in the acquisition of any surgical skill. And certainly on Sunday in the Japan Club, continuing my journey of martial arts in Iaido, I was learning the basics and reinforcing the basics again, because mastery is continual attention to basics. What I was pleased about, I was chatting to one of our students, and Ken entered the room, and a student to my side had poor posture, and he tapped them on the shoulder and said, "Stand up straight." Attention to basics. In the same way, on Sunday, Vincent, who's the sensei, when looking at me carrying my sword, corrected an angle and also could point out when my hips were not straight for some of the cuts. Important to get this correct. And that comes down to what we're going to be talking about today, which is the final part of our banana series of stitching, because the principles of 90 degrees to the tissue, 90 degrees across the tissue, 90 degrees into the tissue remain. And now we're going to go from 2D, as we described last week, on a clock, to thinking about how we look at this in a 3D position. And you'll suddenly realize in the 3D, there's 90 degrees to, across, and in.
Recording in progress.
As point, place, and rotate is actually very important. And that alignment gives you some idea on how to work out where you stand, what leg you stand on, and how you position your lower arm with your shoulder and elbow to affect that rotation. And we're going to go through the principles. I've left in the reading section a history on bowel anastomosis and vascular anastomosis, and we're going to touch on those with a model. And at the end, also going to touch on aortic valve replacement. And although you're not cardiac surgeons, I think this is a wonderful model for practicing valve replacement, but the orientation and the needle alignment are just the same. And that's why I'm going to include it at the end. So before we start, as part of the briefing, has anybody got any questions for our theatre session today, and anything in particular? I do put out questions beforehand and ask people to fill in the form, but unfortunately, not many people fill them in. So please, if you have any questions whatsoever, ask. These sessions are live. They are for you. I'm reflecting last week that Prof. Sile pointed out, I put in an extra stitch, and then we had a fantastic conversation about cognitive overload and trying to rush things and making it worse as I try to complete a second anastomosis within the scripted time that we have. And that all came down to self-awareness, cognitive overload, and being able to step back, take a big breath, drop your shoulders and arms, pick the instruments up again, and realign. Something that we don't often do because we want to just get on to the operation. So let's take you over and demonstrate some of these principles. If it turns out that the model is out of focus, I'm having to do a number of things, watching the screen and watching this. So we talked about the clock, and I'm standing at 6 o'clock, 12 o'clock to my right, 3 o'clock to my left, 9 o'clock. Now spot the problem there because it's port left, which is red. The left is on the red. Okay, port left. So 3 o'clock. Now what I'm going to think about is where I'm going to place the sutures and how I'm going to carry the needle round. So to remind you, the pickup halfway at the tip with no space between the shaft and the needle, angled out, because that's the angle representing the displacement of the wrist from the elbow. As I go around the circle, remember, I'm starting on my left leg, forehand, and coming around. And as I come around each part of this, I'm moving my weight distribution to my right leg. Here, my elbow is leaving my side. I'm stepping into my elbow to reduce the abduction of my arm. But here I've got a problem because now I'm stitching into my right arm. And 90% of surgeons are right-handed. Let me just admit somebody. So there you go. And it's in that position we said, and part of your learning technique is flip your needle over without the forceps. Your forceps are for retracting tissue and not for grabbing the needle, because that will take away from the rotation. So now I'm going from 5 o'clock, 3 o'clock, 2 o'clock, 1 o'clock, 12 o'clock. And as I've gone from my left leg there, I'm now coming around again to my right leg there. This, likewise, is a difficult angle, and lo and behold, in that position, I need to now float to my right hand. All of this is done without a forcer. So this is part of the needle control that you learned going through. And you will have observed, and we pointed out before, on this diagonal, between 4 and 5, or 10 and 11, and that really depends on your own body habitus and size, and you have to work out for yourself. You're going to go from a backhand stitch there to forehand stitch there, and on that side of the diagonal, come to backhand again, and backhand. So that's the backhand half, and that's the forehand half. Now, this is all very well, and this is on a plate, and we are rotating and moving and changing our body weight as we're going around. But it gets now a little bit complicated, because imagine I'm taking this plate and I'm putting it vertical. All right. Now I'm vertical. I'm going to have 12 o'clock there, 4 o'clock there, 6 o'clock there, 3 o'clock and 9 o'clock. And now I have to think in different planes. But this diagonal now becomes also quite important, okay? Because this diagonal, this point now, is the furthest point away from me. And that would be at depth and away. And the principle of all stitching, so you don't trip over yourself, is you stitch towards yourself to the side here, and then from there towards yourself, the side here. You're going round the circle, so you identify the place furthest away. So let's have a look at that as far as a tube is concerned. So here we go, and we're going to focus down. And I'm using, and actually when you do your potato and banana exercises, this is from Mr. DIY. You can get them any DIY shop. In any DIY shop, These are spaces used for putting tiles in a bathroom, but they're beautiful 90 degrees. So I put these all as in a clock, 10 o'clock, 6 o'clock, 3 o'clock, 9 o'clock. And these are all the spaces, okay? And you'll see that I need to be at 90 degrees. Now, sometimes, although I said you've got to be perpendicular to the tissue, sometimes it's actually rather awkward because you're at depth, but you can come in horizontally with a needle like that. It's still going in perpendicular, but my rotation's this way round rather than this way round. And that's what you need to understand. So this 90 degrees across what you want to stitch doesn't necessarily apply at depth, because sometimes at depth one has to rotate the needle into a horizontal plane like that. And in that position, you can still get the needle entering the tissue at 90 degrees. So what does this mean when we look at it? Well, before we go into different sizes, remember that in surgery we are stitching tubes. So by way of example, 12, 6, 3, 9, smaller tube, 12, 3, 6, 9. All we have done is the gearing is less. So the space there is wider than the space there. So when you're joining things, you're placing on one side is that, and if the other side is slightly smaller, your placing's equal, but in a smaller diameter. So if that's the clock and a 2D first surface, now we want to join it to something else, and now I'm looking at it, what have I done? I have now got an isomer here, 3 to 9, 3 to 9, and I've changed the colors. So what I'm going to do now, if you see, if I come up 6 o'clock like that, folding it up, 12 and 6 remain as I join, but 9 goes 3 on either side, 6 to 6. But it's in this position down here, there, and there, that is the furthest point away from me. So it's stitched towards myself underneath and towards myself on the top. And this clock orientation we introduced you to is vitally important because it gives you a mechanism of orientating. So there you go, 12 to 12, 9 to 3, 9 to 3, 6 to 6. And we're looking at it that way. And that's what we need to do. Okay. I'll probably just increase the brightness of the camera a little bit there so you can see the inside. I think Mr. Ardesh has got a problem joining. So there you go. So now I've got two in different planes and working at different angles. And I need to actually think how I organize this. So one of my models, and now to add another complicated layer to this, is a bowel anastomosis, okay? So this is my model of a bowel anastomosis. It is actually made of baby socks. And I think you'd like it, to be honest. What I've got here is mesentery, okay? The yellows are the vessels in the mesentery. So it's very important that you clear the bowel off, but you have a good supply to the mesentery. I've got a mesenteric stitch and I've got an anti-mesenteric stitch. And this is actually useful because if I pass this underneath, I can turn that over and get to the other side, okay? So the bowel being mobile like this, I can get to both sides simply by putting a mesenteric and anti-mesenteric stitch in and bringing it through. Now, I'm not going to attempt with a suture to stitch this because to do this sort of stitching, one has to actually have an assistant. And the assistant and the role of assistant, I was chatting to my fellow sensei, Chris Cuddy, earlier on and exploring at the moment, we don't train, it's naturally assumed. But part of the assisting is being able to follow in a lateral hold and hold the tension in the direction the suture comes out. But that's the second part of assisting, which we do train and focus on in the Black Belt Academy. But what I like about the socks, it does two things. I've got a pink sock with a red sock, okay? Now, I would start my suturing from underneath here at 4 o'clock and come through. But what I'm going to demonstrate here, because the ribs, and I'll focus in on the socks, because the ribs are perpendicular to the edge, I can actually allow come through on each of the ribs of the sock. But this is the mucosa on the inside, and I should not be touching the mucosa as I do this. And I need to go through the mucosa in the same equal and opposite. So there's two layers. And in fact, when you're doing a bowel, you're not going through the mucosa, you're picking the outside of the mucosa and then coming through the serosa on the other side and bringing it together. There are a number of Cornell stitches, Lambert stitches, inverting this because the mucosa on the inside, as you bring it together, should sit together and you can't see. You shouldn't be able to see my ring, okay? But you don't want a continuous suture on the mucosa because that strangulates, and strangulation reduces the blood supply. But this is a good example to use for you to think about and play around, remembering also one thing, and we pointed out previously, that your forceps inadvertently might be grabbing. That would cause a mucosal massacre, or in a vascular anastomosis, endothelial cell genocide. Both are crimes against the body and should be the Hague. But again, I can actually think about how am I going to stitch this? And I should come and line my needle out each side and think about positioning. So when my needle is outside the tissue, I can use my forceps to get the gross position right. But I'm now thinking, what leg am I standing on? What position is my shoulder? What position is my arm as I come round? And you can see that in each quadrant of this, one's going to have a different experience. So from this side, I've got to think, well, what's comfortable? In and out there. Okay. And how do I affect it on the other side? So I'm continually changing my body position and my arm position as well to affect the stitch. For a vascular anastomosis, let's take the mesentery off my model at the moment. Okay. For muscular anastomosis, it is again the same, because one of the most difficult exercises as a cardiac surgeon is aortic dissection. And what you find in aortic dissection is two things. One, the tissue is extremely soggy and wet. And it's the only paper that I found in the Journal of Cardiothoracic Surgery where the import of alignment of the needle 90 degrees to the tissue and across the tissue was described and drawn in a diagram. And it's interesting that my review of OSATs and the binary scoring of stitching, it was 3 cardiac papers and 2 vascular papers that were most detailed. And I believe that's because in vascular surgery and cardiac surgery, we see more, we see the consequences of poor rotation and needle entry immediately with spurting and bleeding. So again, the important thing is, in this case, we do have to make sure it's full thickness and we're picking up the intima. All right, but mindful as I'm doing it, I'm not grabbing the intima with my forceps, but I'm taking from inside out, downstream, if this is downstream, taking the intima onto the adventitia. All right, I'm taking the intima onto the adventitia because I don't want to have a flap because that would be a dissection. And this is now the last level of difficulty with stitching in dissections, in vascular surgery in particular, and bowel anastomosis. Not only have got this in 3D, but you now have got it 2 layers both sides. So you've got double trouble, basically. And the orientation and practice of your needle rotation has to be clean. So this little sock model is just a model for alignment. The important thing when stitching the intima, you should not see any red sock, and you can try it yourself, and red sock, and it should be smooth there. The same thing applies. You should not be able to see any suture, and you should not be able to see the ring, okay? So it's a nice exercise, especially if this is held with an elastic band. How do I actually get to the underneath? So I'm coming in at 4 o'clock. The 2 layers are aligned. Take it through. I need to actually turn it, pick the needle up, deliver it carefully and cleanly, and then from inside out, downstream, make sure I pick it up. If the 2 layers are not together, I need to do it in 2. So you can see now my needle is not quite 90 degrees to the tissue, and I'm using different angles each time. But this dislocation and slip I described is very important. So how can we test this rotation and thinness of a needle? So let's make it simple. We'll come back to the banana. Now, I'm going to take a banana. Okay, let's just see where it's. I'm going to take that one, and I'm going to add one on the side, sitting down. Okay, there. See that ridge there? I'll just draw a pen on that because that ridge there, I think, as I put it down, that ridge there is probably going to be the furthest away from me. What I'm going to do is cut this in half. I'm grabbing a knife from the kitchen drawer. Excuse me a second. Yes, I am in the kitchen on the kitchen island. So let's take our banana. I'm going to cut it in half. Okay. Now I am going to take a teaspoon and I'm going to take out the flesh on this side. Try not to tear the banana. Try not to tear the banana. Sustainable surgery. Have a teaspoon of banana. Take it out carefully, or tore just there. But that's okay. Right, now, we recognize our banana gives me immediate feedback if my stitching is poor. And I'm going to stitch as far away from my site as possible. That's a depth that's there. So I'm going to start here with my needle I'm going to do 4 millimeters by 4 millimeters or 5 millimeters. My elbow's in the air, and there's probably going to be in the way. But this is, and I'll move up here, a bit further around. Past the tear. And the bananas are not fixed on the surface. I use a little trick there in vascular surgery. If the needle is supporting the tissue from the outside. So all the time, I'm thinking about my body position, the pickup of the needle, and rotating it cleanly through. And because it's following two sides, the banana is actually very fragile. And I would usually actually have a suture that would enable me with my spacing. So this is almost an advanced test of spacing because I don't have a suture guiding me where to go. And we've said before that the needle track makes a hole. So entry, I suppose it's not too dissimilar to the aorta sitting in the posterior wall of the abdominal cavity. So that is usually fixed. And you can continue. Along the front. And this is an interesting exercise in practicing your body position and pickup and rotation. So I personally haven't practiced this exercise for a while. So and I would like to commend you to try it yourself and work out the needle positions as we go around. And every stitch, to be honest, and particularly in aortic dissections, every single stitch needs to be precise. Because you can't afford to poor rotation of the needle and you can't afford dislocation or slip. Forceps are not actually grabbing the banana at all. Now I'm seeing some arcs on the banana. It's actually helping, to be honest, with the placement of the sutures. But this, as any anastomosis of the aorta, might take a while. And I'm thinking of last week, do not rush this because there's no rush at all. That is required. What is important is that we get it correct. And the posterior wall, the one furthest from you, is the one that you're never going to see again. And that is the one that needs very careful attention. I haven't done the posterior wall here because I have noticed that the banana is moving around a lot. And I'll think about that for demonstrating the posterior wall again next time. And closing the aorta, I always used to go 4 by 4 by 4, 4-0, and try to go 4 millimeter deep, 4 millimeter apart. And so here, again, all the time, I'm having to think about the angles I'm having to take this needle through and out and try to minimize or increase the rotation every time. Now in this position here, this is the position where if I'm coming from the posterior wall, that's the position I should be ending. Because if you note now, this next stitch, I'm effectively stitching away from me. And the bottom line is, it's because it's going away from me, that's now making it extremely difficult. Because all the stitching should be coming towards me. So just to demonstrate it's difficult, I'm trying to get my orientation correct, but it is proving rather awkward because it's going away. Just notice a little ant running across the surface here. He's don't know where he's come from. High-rise ant. You see how awkward it is to come through an wood. So let's just have a look at that and line it up. And how have we done from there? Okay, so you can do the equal and opposite scores around and equidistant from the edge as well. So a bit like the horizontal banana, we now got a 3D banana. And again, one can practice and look at it and say, okay, how many equidistant from the edge? Okay. Are they equal and opposite? And around the corner, and you can look, did it come out as a clean hole? Or did it come out with a slight skid? Clean hole, slight skid. Coming around this side, that side of the banana. There you go, holding it up. And you can look at the equidistant. So as an exercise, we have taken our 3D banana and we have turned that into an exercise with a sock of alignment of the needle, but testing your spacing and orientation. And doing it on a banana blind is only at the end of the exercise do you actually score it. And you can see if the edges are aligned and if they're opposite. jolly difficult. But the thing about these exercises, they're meant to be difficult to test your ability to get in the right position to effect the perfect rotation. And there's no shortcut, because if this was an aorta and you had a tear, that's a bleed. Getting to the back is difficult. You're going to then have to lift it up and come through the back, and sometimes come through the deep tissue at the back. Okay. Including the posterior wall of the posterior abdominal wall sometimes, and the aorta. But you can see now it's jolly difficult to get your needle through the tissues in these angles, particularly if it's fixed. So this is an opportunity for you to actually think about the needle angle. Once it's coming together along the posterior wall, particularly if you can't flip the aorta over as we did with the mesentery, some of it has to be done over and over from the inside until you get there. But if you've gone 90 degrees in and 90 degrees out, you will get alignment of the sutures. So the important thing also to add here in talking about, and we'll just come back before we demonstrate the aortic model. Just come back to this alignment. So we previously said that all stitching follows these principles of 90 degrees to the tissue, 90 degrees across, and 90 degrees in. But we just demonstrated when you're going around a circle, sometimes instead of doing that way, you need to do that way. But that's still entering the tissue at 90 degrees. But the principle of dislocation, because they're not opposite, and slip, because you're not equidistant from the edge, is important. Now, continuous stitches are strangulating stitches. And certainly on a bowel, if you haven't got the tension right, you will strangulate. There's a Cochrane review in 2006 on bowel anastomosis, single layer, double layer, or stapling. And in fact, there's no conclusion whatsoever. What it did highlight was the very fundamental that we're teaching is respect for the tissue, clean rotation, and this dislocation and slip. Now, whether you do it in 2 layers, and when I was training, we said it's 2 layers, sir. First layer is a continuous suture with catgut, obviously that ages me, and then interrupted sutures for the serosal layer. Whether you do full thickness of the mucosa or not, again, it's down to preference. What you do have to ensure is that the bowel anastomosis is not on tension and that you've got good bleeding edges. So knowledge of your anatomy and the watershed areas between the foregut, midgut, and hindgut is critically important for esophageal anastomosis, particularly up in the head and neck, the upper esophageal anastomosis, and the rectal anastomosis. Now, because the rectum is deep, that is where stapling has turned out to probably have an advantage over others, because stitching at depth is difficult. And staples have come a long way. But contamination, poor technique, under tension, poor vascularization, and notwithstanding the damage that your forceps do, will completely ruin your anastomosis. Now, for arteries, again, if it's too tight, you're going to tear out. Too loose, it's going to bleed. It's got to be a bit like Goldilocks, just right. But for veins are a different ball game altogether. you do not use a full continuous suture around a vein because all veins need to expand to enable you to get an increase in cardiac return. So therefore, you can do half of your anastomosis as a continuous stitch, but the other half needs to be interrupted sutures, such that it allows it to expand. So never, ever, ever do a continuous stitch on a vein. So part of this, I promised you to show you what we've been working on as an idea for a cardiac anastomosis and putting in an aortic valve. So I'm going to take you over again and just demonstrate the model that we've come up with. So I'm going to now do a full thickness apple corer of this banana. I'm going to take that middle out. Okay. Not going to throw away good banana. Okay. So let's imagine we're peering into the ventricle there. Okay. I'm now going to take a bit of sellotape and I'm going to fix the aorta to this, and I'll point out the anatomy in a moment. And take a bit of sellotape. And from there, and take it all the way around. I think I've used all the way around. Let me get my scissors. And really what I've sellotaped on this is a simulated aortic valve. And this is rather fun, I think, because one of the problems is with doing aortic valves is you are seriously operating at depth. So if I'm peering down the aorta here, okay, I would have, they call it an annulus, but it's not an annulus because the aortic cuffs, tricuspid, have commissures, which are demonstrated in red here. Okay, curved watch pocket there, watch pocket there, watch pocket there, which we've taken out. The black mark there is a right coronary artery, and the black mark there is the left coronary artery. And what I'm going to do now is with a needle, I need to stitch the valve in. So now I've got to think, I'm at depth down here. And again, how do I orientate myself? So I've usually start, okay, I usually start with the backhand, which is the most difficult. And I come around a non-coronary commissure, taking the needle out. So this is circular and now at depth, and it's the same thing. And the orientation is going around a clock. And I'm on my backhand at the moment, but I'm finding out as I come to this, that position, guess what? I am now going to go forehand and come in the last stitch here, which will be towards commissure here, is probably forehand. But I'm having to put my needle down and think of my positions. So that's towards myself on that commissure. That's the right commissure. Then I come towards myself on the left commissure, which is where the left coronary artery is. and you're continually adjusting your needle. And sometimes in some aortic valves I've done, when you think that the aorta is a bit more flexible, in one situation, it was so hard, it was literally like a calcified pipe or conduit along the bottom. And for aortic valves, we put mattress sutures in from ventricle side, which is inside the banana, and I put a mattress suture across the base of the commissure. And now I'm on my right leg, and this is now the non-coronary sinus. Okay, the non-coronary sinus down there would be the mitral valve. And we usually use 2A tricron. And this is also a good exercise in knot tying. And tying at depth. And there you go. I've probably got another suture here. Give a suture in here. This side. I'm not sure if I tore that out. What came out, dropped out. Remove that. I think I tear it out and pulled it out from underneath. So, there you go. Let's take this off. That's stitching at depth now. And let's look at the sutures. Are they equidistant from the edge? What is the spacing like? Have I done any tears? Okay, so the banana, there you go, aortic valve replacement. It's giving you lots of opportunities to practice the point, place, rotate, the spacing, and the rotation in each and every position. So what we started off with, the linear incision, point, place, rotate, moving the body round, going around the circle, flipping the needle backwards and forwards, 2 layers of mucosa and adventitia, mucosa and serosa, adventitia and intima, and now at depth. Surgery summed up in exercises that you can use and practice at home. All of these are giving you visible feedback on your orientation, telling you point, place, rotate at every stage, because good stitching is not stitch, 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 stitch. What you have to do is set up and stitch, set up and stitch. And the difference between an expert and a beginner is that setup, because the time it takes you and me to put a needle through the tissue and through the banana is exactly the same. The time it takes you to set yourself up in the right position, understanding how your body moves, how the shoulder girdle moves, in order to get this rotation of the needle, as we described. That is the setup, and that needs to be rehearsed and practiced. And this model, from linear to circle to this dimension and at depth, gives you all that in abundance. The thing is also a bit like the circle. perfection is difficult. Not too bad, could do better. We all could do better. But that's it. It gives you something to practice on and to demonstrate your needle skills in all sorts of orientations. As I started out with this, looks a bit like a hedgehog. So with that, I'd like to actually ask my fellow senseis, and that is Adesh, Chris, Crossile, John Rudd, and some of the green belts I see who have joined us, to pass comment, make observations, and add their thoughts to this process. Sensei Kelly.
Well, first of all, David, congratulations. I've got loads of comments to make, but so you're demonstrating bowel anastomosis, which is not necessarily a one-person job.
Well, I did point that out, and that's why
I know
did not
I know
use
you
the
did.
bread.
But as you were bringing the two socks together, I wanted to go in there and hold the sutures so you could then pass it through and turn it over.
Correct.
But and when you were operating at depth using the aortic valve model, the banana was tilted away from you or towards you, so that the people looking at it couldn't see what you were doing. And once again, as your assistant, I wanted to go in and rotate the banana so that you got an excellent view down it.
Well, there's an interesting one there, you see, because the heart and its orientation, the way it sits, the valve when it goes in, the orientation is across your left shoulder.
Yeah.
And it is towards you. So for an assistant, it is difficult to see. And I appreciate it's difficult for you to see it on there. But you can't orientate that, turn the heart, the aorta is that direction. But it was just a demonstration of, I think, how we can, and we were thinking about how we can, in a low fidelity model, point out the intricacies of needle alignment, etc., through the annulus.
So once again, it's a good example of deconstructing an anastomosis.
Yes.
But the next stage is to bring the two bits together.
Yes.
And for that, you need multiple sutures, and you then put them onto mosquitoes, hold them out of the way. And once again, you probably need an assistant
if not
to get yourself out of problems. But this is all about teaching assisting skills, because I could see the problems that you're going to get yourself into if you carried on the way that you were going.
Of course, yeah. This is the qualification is how do you practice at home by yourself? Yeah. Obviously, in theatre, you've got an assistant, and part of what we're developing in theatre and what you need to understand is how you, as a learning surgeon, are going to direct the assistant to enable you to make that easier. So, yeah, it's rudimentary, but I think fun. And that's the element. But you're quite right. Yeah, and surgery and anastomosis, you need two people. And really critical, I think, in anastomosis is the assistant and the tension that you hold. Yeah. And just to point out that the surgeon takes or should take the thread out in the direction that they want it. And as Jim Monroe said, he's a pediatric surgeon in Southampton, and the first time I assisted with cardiac surgery, he said it's a lateral hold and not a pull. So the surgeon holds the tension, but note I'm holding it between my two fingers there. As soon as you start hooking a finger around, if the surgeon doesn't say let go and catches on that, that'll tear out the banana and tear out your vessel, whatever you're stitching. So holding it between your fingers, lightly, but on a hold, you can feel it move as the surgeon takes it up the next stitch. But the other thing is as you're holding and following a thread, it's 2/5, 3/5, so the surgeon doesn't trip over the excess suture. But we'll go into more detail on the assisting skills. But for the moment, I've lost my assistant, so I might have to borrow one to demonstrate that.
Absolutely. Well, I mean, or Dash or Ken, can you not invite them back to your place and say, tonight we're going to do the next stage? And for that,
Yeah,
they require an
it's
assistant.
a small flat, and my wife
Yeah.
is asleep. So yeah, if I'm not. So, but it's something we can demonstrate and think about later on. But any other comments?
David,
Possibly.
Sile.
Because you're operating at depth, aren't you?
Yes, Prof. Thank you very much. Very interesting. I think this is the second time I learned from you that, the tube anastomosis. That make recall me, I know when I was very early years of the training. And I assisted because I did the surgical rotation as well, during my MO-ship. And then we have a renal transplant in University Hospital. And so that I opened the 3 theaters and, removed 2 kidneys and then they implanted into the 2 recipients. Yeah, all right. This is so great. The donor, live donor. So what happened that then I learned how the surgeon, the anastomose artery to artery and then the vein to vein. And another thing is that in OBGYN, we have like a tubal reconstructions, yeah, when there is a fallopian tubes, and then if there is any fallopian tube damage. Those days, IVF is not really popular and easily available like these days, yeah. So that they try to preserve the tubes, fallopian tubes. Nowadays, it's easy. If any tube damage, better take it out. And then because if we repair, and then that might cause ectopic pregnancy, in that the anastomosis site.
Is that a serious risk of ectopic if you try and repair a fallopian tube?
No,
Are there
it's
any things you can do to
usually
mitigate
we
that?
do repair in previously someone who had it tubal ligation, they cut the tubes and all. It's not just like it, they cut both tubes. So it's like the 2 tubes, the end apart. So then when she got a new union or something like that, when the husband passed away, and then they want to get a child for them, then, they do rejoining. So that is quite, that fallopian tube is very dedicated and then also very tiny. So usually we put like, we cannot put like 12 o'clock. Maybe we can put like only 4 stitches, the maximum 4 or 8 stitches, yeah. But again, in your demonstration, you demonstrated in a very first step with only needle alone. Yet I agree with Prof. Chris that if with the thread, that will be, like a bit more challenging when you put the needle in together with the thread, so that you must know how to manage this thread not to lock. Sometimes like it's going into a wrong way, then it's a hook below it, so there's just a lot of trick things to practice about that. So the very first step, I 100% agree with you that with the loose needle to practice. But in the next practice, if you're very happy about this, the needle positioning, then the next step should be with the thread, or either interrupted, or otherwise continuous.
And as soon as you put the thread in, I've tried it before, you have to have an assistant. Definitely. And I'm on a kitchen countertop here in an island, and the assistant would be a meter across the other side, so leaning across. And on the island, then my camera's right here as well. So to assist us also is a difficult model on this, although we have set it up on the ironing board, which is a good operating table for people to assist. But as was pointed out the other day, we were talking about assisting as well, and teaching that the assistant and the surgeon have to be at the same height. They've got to be able to look each other in the eye, but there's got to be at a height which is a functional height for both of them. And otherwise, both will either, or I'd say both are compromised. But we'll come on to talk about that as well. Soon.
Yeah, in the next silent mentor session, if we have an opportunity, maybe we can video record it by using the silent mentor.
Yes,
Yeah.
I'd be very happy to. Yes, I think that's
Yes, yeah.
I'd be very
Because
happy.
when I saw that your open cardiac, the heart
Yes.
with
Yeah.
silent mentor, the tissue are so fresh, very
Oh,
fresh,
Well, I'm presenting to the
especially
faculty.
day one. Yeah.
I'm presenting to the Faculty of Medicine tomorrow because
Sure.
I think that the dean and the faculty committee, because I think that the learning opportunities for anatomy and practice of surgery to this extent are wonderful for both undergraduate and postgraduates. And it's my wish to see it as incorporated and recognized as part of undergraduate and postgraduate curriculum. So that is part of a strategy. And you'll like it because I'm calling it HANDS. And the HANDS actually is the humanistic anatomy and silent mental combination. And it's bringing, remembering that the healer is the philosophy, the hands is the execution, but the hands also with the silent mental brings in that it's not anatomy, there's a person who's dedicated their life to your education, which, as Chris has seen the silent mental program, is a unique and absolutely wonderful education experience that I'm hoping to embed into the way University of Malaya Faculty of Medicine teach anatomy, practice surgery, and extend it into the master's program. I'd quite like to see us as the center in the Asian region for anybody wanting to do surgery, because we have all the ingredients there to make it a really quite an exciting program. That's my vision.
Thank you very much, Prof. Yeah, that's a very kind of Vice Chancellor as well. And recently, silent mentor program received very much outstanding awards
Indeed.
from the Vice.
Yes, yes, I know.
Yeah.
I know.
Yeah, this is their great love of the silent mentors. Thank you very much.
So, any other comments from anybody? Observations, Mr. Kelly?
Loads. So you're going to have to deal with faculty in the university very carefully.
Yeah, well, let's
Because
talk about that off this. Chris, please.
Offline, absolutely.
Offline, please.
But the fact that Seeley was able to recommend Silent Mentor, fantastic.
Exactly.
So
Well,
the willingness
won
is
awards.
there. It's just a question of grounding it and making it happen.
Yeah, we'll have the conversation offline. So the banana, you can see the marks. You can see the marks. You can even see the marks from the inside.
Yeah.
What's interesting, I've done the same for top-end coronary anastomosis, and in that situation, we've peeled the banana to make sure that your 6-0 needle's gone through full thickness of the banana, so you can score the radiality from underneath. So taking cardiac surgery to another level with top ends and castros and 6-0s. Any questions from anybody else? Any observations?
David, yes.
Yes. So
I
John,
never cease to be amazed at your inventiveness of these models. They're so cheap. Anybody could do it. Well, not invent, but anybody could use it. And when you think about wet labs and the cost,
exactly.
you know, it's amazing. The only other question I had, and I'm probably jumping light years ahead of what we're doing, but would a barren blade be, that's not a barren blade, a needle holder? You know, the Castro is what I wanted.
Yeah, the Castro needle holder is used for coronary anastomosis and top ends. The rotation there is actually there. What's interesting that the rotation is not a flick of the wrist. As we've said before, that the wrist is flexion, extension, abduction, adduction, so that's circumduction. So for the use of a castros, then I'd say that your wrist, your elbow, and your shoulder, put your castros in the position of point place rotate, and you're literally rolling the barrel of the castros as you're rolling a pencil. That's the action.
So
it's a simple finger movement. There's no wrist
so what
movement.
you're really saying is you would probably use a castro.
For yes, and for bottom end practice, and I know Mahesh is doing that because I've shown him. You poach an egg, so it's hard, and then make a 5 mm incision in the white membrane of the yolk. And I'm not yoking, boom boom. And you use a needle only to take a 7/0 needle in and out of that membrane without tearing the membrane or scrambling the egg. Now, it's a 7/0 on a wet, sticky surface, but the needle control is just as we've described. Obviously, the needle is the size of your eyelash, but the principles are the same.
Anyway, all I'm going to say now is thank you very, very much.
Well, thank you, John. Ardesh, I saw you come in. Ardesh was next.
I was going to suggest that Ardesh come in at this stage.
Yeah, he did. He appeared. Welcome, Ardesh. Give him a big round of applause. He's past his third year.
Yeah, thank you so much. Hello, Eddie. Hello.
Turn your mic up, please, Ardesh. Or speak up.
Sorry, can you hear me?
Yeah. Speak up louder.
Right. Okay, can you hear me now?
Yes, better.
Okay. Sorry, Prof. I just wanted to say today was an amazing session, really mind blown. I've never seen bowel anastomosis before, and the fact that you did it easy on a banana, really looking forward to try it on Friday.
Yeah, that worked this evening, didn't it? Yeah, that's fine. And look forward to trying it at the session. But it gives you that idea of how to orientate your needle at depth. And it is challenging because it's rigid. Obviously the aorta is not, but I have come across it previously. Good. Any other observations, Adesh?
Yeah, Prof. So I noticed that, okay, for the bowel anastomosis, so you use the needle holder and then you drive the needle in, but then you pick the needle up using your forceps. Do you rotate the needle or do you just pull it out?
No, you're quite right. The needle there was there not to pull it out. The only time you actually use the forceps when you're stitching is if the needle is not held in the tissue. Now, sometimes with bowel, and we've been practicing on the banana, the needle is held in the tissue. Sometimes on thinner walls and thinner tissues, the needle is not held. And the important thing is not to use the forceps to deliver the needle. You can use the forceps to hold the needle in position and then apply your needle to continue the rotation. But the problem is that people usually grab with the forceps and drag it out. That's one thing you must not do. So if I did it this evening, you picked it up, error.
All right. Thank you, Prof.
Any other observations or comments? Oh, you know what I think happened? I think our record button did not work, did it? Chris, did you hit the record at all when you came in?
It's still recording.
Is it still recording? Okay.
It's still recording.
Still recording. I just looked at that thinking, not recording. Anyway, and with that, it's still recording. I wish you all well, wish you a good evening. Thank you to my senseis who joined us this evening. Go away and practice, and I'm going to contemplate what we're going to discuss next week. I've got a couple of guest speakers lined up, and what we're going to do is dependent on their availability as guest speakers. So thank you very much indeed. Look forward to seeing you next week, and I wish you all well.